today is basics parts of the admittance of a patient. So I'm going to be going over a couple of forms that are related to the surgery that we're doing today. So the first thing is going to be the admittance form. So our forms kind of have a couple of them combined. They do have our anesthesia consent form, and it does have all the signalization and patient information on here. You know, it has all that kind of stuff. So for this form, we call it our surgical anesthesia consent form. So up at the top here, we have our patient information, client, you know, the client name, address, things like that. We'll have the patient name, the age, and down here we'll have a spot to record when the last time that the patient ate, you know, a last time that dog was in heat if we're doing a spay, and a list for a current weight, and a spot for current medications that the patient may be on. And then below that we will list what procedure that they're having. So the next part is going to be going over the risks of anesthesia and kind of going over with the client what we're doing for the procedure today. So what I would, you know, talk to the client about in, you know, when presenting this form to them, I would say this part goes over the just the risks of anesthesia. It will say that you know, there can be complications. We are doing a physical exam, but that may not necessarily cover everything. So we do recommend doing pre-anesthetic blood work, which we'll cover later in the form. And so just saying that this is something that Dr. Turner recommends. And things like that. So into that we do go over the pre-anesthetic testing that Dr. Turner recommends. I will mention that is highly recommended for the procedure that we are doing today. Sometimes Dr. Turner will require it for certain more advanced complicated procedures, and I will go over the fact that it looks over, you know, blood counts such as like white blood cells, red blood cell count, things like that. You know, it'll look over some certain organ functions. We'll look over the BUNs, creatinine, liver function, glucose, phosphorus, amylase, sodium, things like that. So we'll go over that, and then they'll have the option to approve or decline that. And then there is a section for them to sign and state that they understand they're taking full responsibility for the charges. They authorize the anesthesia of this patient, and, you know, to perform any other things that we may see are fit during this procedure. And so the next part is going to be to make sure that we do have the patient's file. In this file, we aren't digital, so we do have paper charts. So this file is going to have all the permanent medical history for our patient that we're doing the anesthesia the procedure on today. You know, we'll have their patient information, having all their previous history up until this point. This one has the previous vaccination history. This one, you know, happens to be their vaccines from the breeder, and it also has the client's information. So you do want to always keep this, you know, we're going to always have this chart on hand. This follows us wherever the patient goes, whenever we're pulling up medication, everything like that. So this is all the information we'll need for the patient. We'll have all of their forms for the surgery with us on hand in the chart, so we can have access to all of their information at one time. The next part is going to be, you know, so in addition to having all these forms, we do want to make sure that we're keeping everything, having the correct identification for our patient. That way we're keeping track of who we're working with, who this patient is that we have in our kennels, and just making sure that everything is keeping organized and we're keeping track of everything going on. So the way that we make sure that we identify our patients correctly is we do have these little collars that are basically like hospital bands. It'll have the patient's name, it'll have their client information, the name of the owner, their address, and then we'll have our clinic phone number, and we'll also have our clinic address and name as well. And the other thing is going to be their cage card. So this is the form that we have for our cage cards. This will be attached to the actual front door of the cage. just to make sure that we're pulling out the right patient and making sure we know who they are, what they're here for, and what's going on. So at the top we have the dates that they're here and the dates that they're going home. Whether, with our spays, they do stay overnight, so that way we know that they're going to be here overnight. We have the patient's name, what kennel it is that they're staying in, and then we do have an option for what they are here for. So we already have a couple of our very common procedures, dentals, spays, neuters, declaws, things like that. And then we have a spot down here for any additional problems or, something different that may be going on, like if they're here for a tumor removal, things like that, or if, they need vaccines, we're going to place that there. Other than that, we also have, information of things that they may need, blood work, vaccinations, things such as simple as bath or a nail trim. And then under that, we do have the information of things they brought with them so that we make sure they go home with what they came with. Leashes, medications, bedding, food, anything that the owner will bring with them. So that will be their identification. Other than that, we do, for some of our procedures, obviously we will be sending off like some mass removals. We will be sending off the masses and tumors just to the laboratory, or we may be sending off certain like blood work, chemistries, different things like that. So I'm just going to go over a couple of those forms. The first form that we do use a lot is going to be our ANTEC form. This is where we send off all of our out-of-house blood work that isn't just a basic CBC or chemistry or urinalysis, things like that. Then we have our form already set to go with our clinic information, and then we can insert our doctor, the doctor name, the patient information, and signalization and stuff, and then we will select which chemistry and lab work we are wanting to run, things like that. So, and then we usually send off to our veterinary diagnostic lab for the state of Arkansas, to the Arkansas Livestock and Poultry Commission. So that's what this form is. Us as techs, we will fill out our the client's information and then our information for the clinic. Go over, insert our patient signalization, things like that, and then our doctor will go in and say where the mass was located, fill out all the information that the laboratory will need regarding that mass and that specific patient. So that's pretty much that. And then that's for before and after the procedure. So for during the procedure, we do keep track of the anesthesia on an anesthesia monitoring chart. We have ours on the back of our procedure sheet. So our procedure sheet is going to have we'll fill out all of the what medications, pre-medication, induction, pain medicine, all the main ones that we normally use are on here. We have a chart that will fill out, do all the calculations for us, and that way we can keep track of and then we also have a way to keep track of when medications were given, at what time, and people will fill out the initials so we know who gave it, what time, what method, IM, IV, things like that. And then we will also keep track underneath that. We'll say what procedure it is, who helped out the doctor today, and then we'll fill out, times that the procedure started, anesthesia started, and then Dr. Turner will fill out his procedure notes. I'm down at the bottom. And then on the back is, like I said, where we do our anesthesia monitoring. So we have a chart that we will fill out every 5 minutes. We'll have our temperature, heart rate, respiratory rate, SpO2, what ISO percentage they're on, what flow rate they're on, and any fluid rate change, or none if that may be the case, and anything else that we want to note as far as our procedure goes. So then we'll, once the procedure is done and we've gotten everything taken care of and it's time for the patient to go home, we do have our home care instructions that we send home with our patient. So basically this will go over all the different risks, things that they were going to notice while they're at home, pain medicine, just all the things summed up into one little neat package. So for our home care instructions, we go over the patient name, the client name, what date the procedure happened. So we'll say your patient was here for this procedure. So when we're speaking to the client, what I'm going to say is that today. So Addie today is going to be a little bit groggy and nauseous. This is just from the anesthesia. It's normal, but it takes about 24 to 48 hours for the anesthesia to work out of her system. So for tonight, I will probably go ahead and just feed her a little bit of food, just to not upset her stomach, and monitor for any vomiting afterwards. You know, make sure they have plenty of water, but after that first a couple days, you may resume the normal diet. You want to keep them as quiet as possible for the next week while they're healing, in the recovery process. This includes leash walking at all times, you know, when you're letting them out to go to the bathroom, not letting them roughhouse and play or anything like that that may cause problems to the incision site, or, you know, cause any damage or to rip out any stitches, things like that. You know, we want to make sure that you're checking her incision, make sure there's no swelling, discharge, redness, things like that may be, you know, want to make sure that they're not licking or chewing at the area. If this does become an issue, you can always, you will need to get an e-collar, and we can send you home with one of those to discourage your pet from licking at the incision site to promote the easiest healing possible. Today for this particular patient, you know, she does have stitches, but they are absorbable. So if we do have a patient that does need stitches, we will let them know that they will need the stitches out in 10 to 14 days. Usually we'll offer them to go ahead and make an appointment, or they can call back closer to the time. You know, and then the next part, I will go over the medications. So for our everyday procedure, you know, our daily procedures that we normally have, our spays and neuters and things like that, we usually send home meloxicam. I'll go over with them and let them know that their pet already got their first initial dose today, and they can, and we already have it pulled up in a syringe, already pre-dosed and ready to go, so they can just give one syringe once a day starting tomorrow. We'll let them know that what time their pet got that medication today, and that's when it'll be due tomorrow and every day after that. So as far as meloxicam goes, some of the side effects for that could be, it is an NSAID, so some of the side effects for that are nausea, vomiting, diarrhea, loss of appetite, and also it does include the, it is an NSAID, so it does have some of the long-term side effects that all NSAIDs have, stomach ulceration, unusual bleeding, and loss of kidney function. So when we do, part of the, you know, which is also a good reason to do blood work to make sure that there are no kidney problems, so we don't accidentally give this medication to a patient that does have kidney problems. And at the end of our home care instructions, we do say to make sure, you know, to give us a call if they've stopped eating, stopped drinking, or if the incision site does look red and swollen or oozing, just to give us a call, or if they have any questions, to give us a call at that time. Alright, so to hold for a jugular blood draw, the first thing you're going to do is, it's probably easiest to have the dog sitting, and when you're holding, you're going to take all of the collars and leashes, things like that, and you're going to hold it up in your hand with the head. So when you're doing that, you're going to hold the head back and just hold the patient for the blood drawer, and they're going to hold off their self for the jugular blood draw, and then you're just going to make sure that the patient stays as still as possible, moving their head to either side, depending on what side of the neck they're going to be drawing the blood from. Alright, so when you're holding for a cephalic blood draw, you're going to hold onto the patient's head and hold it out of the way, keeping control of the head in case of any, you know, if the patient tries to bite the drawer or anything like that. So you're going to go ahead and hold on to the head, and then you're going to take, with your 2 fingers, take control behind the elbow, and then you're going to use your thumb and roll the cephalic vein and hold off really tightly. So when you're holding off for a saphenous blood draw, you're going to have your patient in lateral recumbency, and so you're going to take your hand right here at the stifle joint and just gently extend the leg if you can, but take your finger and hold off right there at the back of that joint, right kind of where the leg starts to bend, and you're going to hold off right there, tightly holding off the vein for the drawer. Alright, so I'm going to be demonstrating how to get your patient correctly in and out of a cage. So I already have Rudy here on a slip lead. So when you're putting your patient back in the cage, open up your cage and lead them inside. If you are dealing with an aggressive dog, you do want to be very careful. But you're just going to go ahead and remove the slip lead from their head, and then you're going to close the little door, making sure it is latched, and then using any sort of device to lock the cage. So then when you're taking them out of the cage, you're going to have your slip lead again, and then you're going to just open the door gently, very slowly, making sure they're not going to run out. And then you're going to just slip the lead over their head and let them walk out themselves. Okay, so you will have patients that are a little bit smaller that won't be able to just walk out of their cage, whether it's up higher or things like that. So when you have your patient, you're going to go ahead and open up the door, and then you're going to gently pick them up properly. Supporting their body and getting them in the cage. And then like I said, take off the slip lead and then close the door. So when you're taking them out, you're going to go ahead and open the door, and then you're going to support them, their whole body, and gently get them out of the cage. So when you're applying a muzzle on a dog, for really aggressive dogs, you may want to have an extra handler on hand, but either way, you're going to always be sure to be super extra careful when applying a muzzle. So first you're going to get the correct size muzzle. You want to make sure it is tight against their muzzles to not let any sort of allow them to open their mouth to grab you at all. So when you're doing it, it's going to be best to take it from the two sides. Sit. And then sit. Sorry. And you're going to go from behind. And you're just going to slip it right over their head. You may have to adjust the straps, but you're going to just buckle it and pull it tight to where the straps are flush with their head and they can't slip it off in any way, or at least as best as possible. So you do, like I said, you want to make sure that it does fit snugly. Around their muzzle, so that to prevent them, so make sure that the muzzle does its job correctly. Alright, so when you're fitting a Elizabethan collar for a patient, the two things you want to make sure is that it's going to fit around their neck, and that this part is going to be past their nose, as to make sure that they can't get their nose past the e-collar and just make it pointless for them to wear it at all. So I'm going to go ahead and be testing this with Rudy. So you're just going to want to test it and wrap it around and make sure that it can go to for this one, you have a couple of different options for sizes, and you do want to make sure that it will fit with one that probably won't foot over his head when you do set it, and then you can already tell that it will, it does go past his nose. He does have a little bit of a longer nose, so you do want to make sure that it still fits past it. That will be the most important part, for it to fit past his nose. So for this one, I do, it has little loops at the end that I've already set up, and this is where the collar will go. So I'm going to go ahead and get this one set up for Mr. Rudy today. Alright, so like I said, for the specific e-collar, it does come with loops that you are going to feed his collar through. And so you'll take the collar off, and then you'll feed the collar through, and then you will just slip it over his head, like so. And that collar, slipping it through the collar will make sure an extra little layer to help make sure it does stay on his head. But you do want to make sure and test to make sure it is not going to be easily pulled over his head, just in case he's going to try and pull it off, as they don't like it. Make sure he's not going to be able to pull it off himself. So in addition to any lab work or testing that we may do before putting a patient under anesthesia, one of the most important parts is doing a physical examination. So the doctor will be doing a more thorough physical examination to properly determine whether or not he or she feels like the patient can go under anesthesia. But as technicians, it always is good to do a physical examination as well. We can look at the patient's eyes, ears to see if we see any debris. For her, she does not have any debris or anything like that. I can go ahead and look at her, mucous membranes, her teeth, and everything looks nice and pink. Just kind of feeling around, looking to see if I notice any abrasions, any lesions, anything that would stand out that may cause concern for putting this patient under anesthesia. And so far, I'm not seeing anything with her. Like I said, mucous membrane color, capillary refill time, her gums are nice and moist as well, so no really signs of dehydration or anything like that. Okay, so when you are doing the physical exam, the main thing that you are going to be doing is a TPR and auscultating the heart and lungs. So the first part of TPR is going to be temperature. So we're going to get a thermometer, and we just have a regular thermometer here, and I'm going to insert it rectally. Do want to make sure you do have lube, plenty of lube. So that is going to be the T for TPR, and then P is going to be pulse. You can either feel right under the left side, and to feel their heartbeat, or you can feel their pulse back here as well. But you can also, a great way to get the pulse is using your stethoscope, because you can hear it well and make sure, especially if they have fast heart rate, you can make sure to get the correct pulse. And then respirations, you can just feel. So when you're doing the pulse and respirations, you can count in a 10-second period or a 15-second period. If you're doing a 10-second period, you can times that number by 6 and get your pulse and respiration for a minute. If you're doing it in a 15-second period, you'll times it by 4. So I'm going to go ahead and get this information from Miss Gypsy here. Alright, so I got a pulse of 14 in 10 seconds, making a 144 beats per minute, which is great. And I'm just going to go ahead and listen to her heart while I'm here. I'm not hearing any whooshing sounds or anything like that. That would be indicative of a heart murmur. Just going to go ahead and listen to her lungs. And her lungs sound great, no crackling or wheezing. And I'll go ahead and get a respiration. So I did get 10, so I have a respiration of 60, which as well is good. As far as temperatures, you want to make sure it is in between the 100 to less than 103 range. Her temperature was 102.3, so that would be a normal temperature. So for her, I would give her an ASA score of 1. Alright, so when you're performing a physical exam on a cat, it's going to be basically the same as it would be for a dog. So like I said, you're going to go over just the main focal points. You're going to look at her eyes, make sure there's no discharge, anything like that. Check her ears, look for any obvious debris, redness, irritation, things like that. She looks great. And then you're going to look at her mucous membrane color. And hers are nice and pink. And then again, feeling for any lacerations, any noticeable things like that that you need to be alerted of. Even things to notice such as like fleas, anything like that, skin irritations that you may notice, like if they have like a rash or a small skin infection. You may note, if you notice those, you may note that to the doctor. And then getting a TPR as well, so those are going to be your main thing. So go ahead and get a pulse on her, feeling on the left side of her chest. I got 132, and then getting the respirations. Got 7, so it'll be 42. And so then now finally I'm going to go ahead and auscultate the heart and lungs. Alright, her heart sounds good, no signs of a murmur. Alright, and breath sound great as well. So I'm going to go ahead and give Miss Ruby here an ASA of 1. So this is going to be the cephalic vein on a canine. Okay, we're going to be doing a blood draw from the cephalic of Miss Ruby here. Okay, this is going to be the canine jugular draw. So we're going to be doing the jugular for the cat. So this is going to be the canine lateral saphenous. saphenous vein for a cat. Girl. I am going to be using a butterfly. Alright, so when you have a patient here that is going to be going under anesthesia, there are a few minimum databases that you do want to check for before you want to make sure that they are good to go before they go under the anesthesia. So the first one you're going to test for is the PCV, packed cell volume, or also known as the hematocrit. And what that does is measure the amount of red blood cells in relation to the whole blood. So for canines, that normal is going to be about 37% to 54%, and that is a good way to notice to see if they're, dehydrated, or if they're losing red blood cells, anemic, things like that. For felines, that number is going to be 27% to 48%. The next database you're going to be looking at is the total solids or proteins. So what that does is it looks at the plasma proteins in the blood. That one is going to be measured with a refractometer. And so for dogs, that number is going to be 5.5 to 7.5 grams per deciliter. And for cats, that is going to be 6.5 to 8.2 grams per deciliter. The next database you're going to be looking at is going to be your blood glucose, and that looks at the the endocrine function of the pancreas. So with that, you're just going to get a small blood test and test with the glucometer. And for dogs, that number is going to be 80 to 130 milligrams per deciliter. And for cats, your normal is 70 to 180 milligrams per deciliter, but that number can go up if your cat is pretty stressed. Next database you're going to be looking at is your BUN, and that is the kidney's ability to remove the nitrogenous waste from your blood. And for that is going to be the normal for dogs and cats is 5 to 35 milligrams per deciliter. And the last one you're going to be looking at is your alanine aminotransferase, or also known as the ALT, and that tests for the function of the liver. And for dogs, that normal is going to be 8.2 to 109 units per liter. And for cats, that number is about 25 to 97 units per liter. So after you've done your physical examination and your minimum databases, if there are some patients that you notice some abnormalities, like maybe you notice a heart murmur, or maybe they seem a little bit anemic, or things like that, you do want to do some additional testing. So that additional testing can be larger blood panels, such as a full chemistry and CBC, or doing radiographs, things like that, if there are some things that we do find abnormal. We can even go send those levels, maybe send off some blood work, things like that. Sometimes we'll have patients that we do notice that their liver is a little bit off, so the doctor will decide to go ahead and put them on IV fluids, things like that. We'll have even if we don't find something, even when they're like geriatric patients or maybe patients that we already know are a little bit high risk, we'll go ahead and run some of that extra blood work just to make sure that all the levels are looking good before we want to put them under the anesthesia. So the next step is going to be determining our anesthetic protocol. So for our clinic, we already have a procedure sheet set up in Excel that already has all the calculations we need for all of the main common pre-medications, inductions, and pain management that our doctor, Dr. Turner, does use in clinic with our procedures. So the first thing we're going to need to do is determine the weight of our patient. So for this patient is going to be 17.7 pounds. And you'll just go ahead and enter. It'll come up with your kilograms, and then it'll go ahead and list all of the dosages needed for each of your medications. So Dr. Turner today has determined that he wants, for the pre-medications, he wants to do acepromazine and atropine for our spay, and then the induction we will be using telazol. So for the acepromazine, we're going to pull up 0.03 milliliters. The atropine, we're going to pull up 0.49. And for our telazol, we're going to go ahead and pull up 0.24 milliliters. And then, so once we get all that pulled up, we'll go ahead and pre-medicate our dog at least 10 to 30 minutes, probably before the procedure. And then we will go ahead and induce our patient with the telazol, and then we will be ready to go to intubate and get it started. Alright, so since we've determined we will be using telazol for our induction agent today, telazol is a controlled substance. So we are going to need to log our the telazol we just pulled up into our controlled substance log. So for our controlled substance log, we do have everything in a binder ready to go. We have all of our different controlled substances already labeled in different dividers. So I'm going to go ahead and go to our telazol. We have ours in alphabetical order. Alright, so we do have our previous logs ready to go. We have our drug name, our strength, the method in which it is given, dates, bottles, things like that. So we know we have this much already on hand. So for my patient today, we are going to be doing, I pulled up 0.24 milliliters of the telazol. So I'm going to go ahead and insert all this information. We have our client name, which bottle that we pulled it from, the date, our patient name, and we are going to give 0.24. Then I'm going to add my initials in and then subtract it. Subtract the 0.24 from our balance on hand so that the next person knows how much is left in the bottle. Alright, so I'm going to be going over our anesthesia machine. So first of all, this is our oxygen tank that we have hooked up to our machine. Right here you'll have the pressure gauges, and then we have two different lines going off of it, one for our dental machine and this one for our one in here. So this line does connect over here to our oxygen. So this is our flow meter. This you'll be able to increase, you'll turn this knob and you'll increase and decrease the amount of oxygen that is flowing through the system, both to make sure that the correct size patient is, or the different size patients are getting the correct amount of oxygen, and the more oxygen that is flowing through the system, the faster that the patient will get the anesthetic gases. So this is going to be your flush valve as well. You can flush the system with some more oxygen. A use you can use for that is to either flush the oxygen out of the system when you're turning the oxygen off at night, or if you're trying to fill up the bag to try and get, manually get the patient to breathe. So moving on, then you go to the vaporizer. So we have an isoflurane vaporizer here. So when you turn it on, you'll push this black button on top, and then you'll just turn the increase and decrease the amount of isoflurane that is flowing through the system. This right here will show how much isoflurane is in the vaporizer for this system. You do want it full at the top of this black dot right here. This right here is where you'll open up and fill with your isoflurane. You don't want to, you don't want to have it open too long, or it will start vaporizing into the air. So over here we do have I have a rebreathing circuit attached right now. It is attached to the side that says inhale, and it does have a sticker on here that says inspiratory, so that shows me that I need to put it right here at the inhale. And then this right here is attached to the exhale. So with the rebreathing circuit, you're going to be doing this for your larger patients. So patients, we usually say generally over about 20 pounds. So when the patient inhales, they're inhaling the oxygen and the isoflurane, and when they exhale, their exhale gases are sent through the system and put through the scavenging system, removing the CO2, and then those exhale gases are actually put back through the system and they're going to be inhaled with the fresh oxygen and isoflurane. The next part we have here is our reservoir bag. This is going to be kind of what is kind of be like their lungs that will help move everything through the system and hold the excess air as well. So a good judge for getting the size for this is kind of based off of how big relative to the size of their lungs. So this here is the pop-off valve. It can be opened or closed. Then this goes on to our scavenging unit. Right here we have our CO2 canister or soda lime canister. These are both called, and these soda lime granules do filter out the CO2. As you can see with this system, we're already starting to get a little bit of a line of the granules turning purple. This shows that these granules have absorbed as much CO2 as they can possibly handle. It's probably starting to get time to replace those granules. This right here is our pressure gauge. And like I said, we're going through our rebreathing system, and this goes down to our CO2 canister down here. So the next circuit, the other circuit that we will use is a non-rebreathing circuit. So this will be used for your smaller patients that don't have enough exhaled airflow pressure to be able to really get the air moving through the system. So the way that you're going to attach this one is you're going to attach this one to the oxygen, and then this will be directly attached to the scavenging system. And then over here you will have your open and close valve right here, and then you'll have your reservoir bag attached at the end, and this part will be attached to the endotracheal tube. So this one, they will inhale all of the, through this tube they'll be inhaled the fresh oxygen and isoflurane. And then when they exhale, it will be sent through, again, directly through the scavenging system to scavenge out all those exhaled gases. So they're not going to be inhaling any of their own exhaled gases as with you would the rebreathing circuit. Like I said, just because they don't have, the smaller patients don't have as much pressure and airflow going through the system. So sometimes you may be inducing the patient through inhalation versus intravenously. So there are two ways to do that. First is with masks, and the mask will be attached to the end of the circuit. So this rubber part right here will go over their muzzle. There are different sizes of masks. There are small, tiny ones that can be used for like cats and even smaller animals, growing up to different sizes based off of how large the animal is or isn't. The other thing to go over is induction chambers. So we don't have an official one, but we do have a makeshift one. So what it is a chamber that can be securely closed, and it does have a hole at the end that will be attached to the circuit at the end, and attached to the circuit that will be attached to the anesthesia machine. So we use these for smaller patients, or cats or other animals that may have become fractious and won't sit still for an IV induction or even a mask induction. So when you're testing for leaks, the first thing you're going to do is go ahead and close off this pop-out valve. Next thing is you're going to go ahead and close the end of the circuit, with your hand, thumb, anything like that. So then you're going to go ahead and flush the system with oxygen, filling up the reservoir bag completely. So you want to get sit here for, you'll fill it to about 20. You'll fill it up the pressure to about 20, where that pressure valve says about 20. And then you're just going to sit here and watch that valve for about, you're going to sit there for about 5 seconds, watching that valve, making sure that it's not going down at all, and making sure that there are no leaks whatsoever. So once you've done that, you can go ahead, and it's probably best to go ahead and let go of the pop-off valve. That way you can make sure that everything is flowing correctly through your scavenging system, and that you'll know that it's open for your patient and coming up in the future. Once that opens up and then you can watch the bag fill out, you can go ahead and make sure that everything flows through the way that it's supposed to flow through. So while a patient is under anesthesia, it is super important to monitor them during the anesthesia procedure. So you're going to be monitoring their heart rate, breathing, just everything to make sure, all their vitals, just to make sure that they're still stable, and it will help you determine whether or not you need to adjust their anesthesia levels at all. So the first thing that I'm going to go over is our pulse oximeter. So we have this system here. It will go over the percentage of the oxygen that is in their system, SPO, or is also what it's called. It'll tell us their heart rate. It'll also have a audible sound of their heart rate as they're under anesthesia. It'll have an alert whether or not their heart rate is going too high or too low, or whether or not their oxygen percentage has gone down below 94%. So that's what that is going to test. When you're putting it on the patient, you're going to, there's two different ways, two different little ends that we have. The first one is this little clamp. You can put it on their tongue or on their ear, kind of a fleshy part that's really, really close to some veins. The other way is with this little end right here. And this end you can put on the pads of their feet, or we commonly put it at the base of their tail. We'll shave a little area of hair and put it at the base of their tail, right where that vein is. So the next piece of equipment that I'm going to go over is the esophageal stethoscope. So what this does is it's literally a little bit of a microphone at the end that will pick up the heart rate and the respiratory sounds. And so what you do with this is you will attach it to an amplifier. We'll attach the end of it to an amplifier, and we have it attached to a speaker system that will be going during the procedure. That way we can literally listen to the heart rate and the respirations. So when you're inserting this into the esophagus, as the name suggests, it will be going into the esophagus instead of the tracheal, like the endotracheal tube. So what you're going to do is loop up the end of this tube, and while the patient is already intubated, you're going to go ahead and insert this into the mouth, down to the esophagus, just as you would during your intubation. And the way that you know that you're at the spot is that you're hearing the heart rate and the respirations. So you'll know if you've gone too far if you start losing your heart sounds, or your heartbeat, and your respiration sounds. This is great because it can be kind of as a backup to the pulse oximeter that can, and give you a more accurate representation of the heartbeat, and make sure that you can kind of hear those respirations to hear, really, mostly as a backup and as a support, just to kind of make sure you're getting the correct information.
I've got Rudy here, and today we're going to be performing an ECG on him today. I've got my machine all ready to go. It's turned on. So the first thing you're going to do is make sure he's not on a conductive surface. So we've got him on a blanket right now. And then you're going to place your leads. So the first one you're going to place is your white lead, which will go onto the right front. Yeah. And then I'm going to spray with some alcohol first. It's okay, bud. You're doing good. and you're going to place it right below the elbow. And then, so this is a 3-lead system. Some of them do have 4 with a green lead, but this one has 3. So we're going to do, a good trick to do is smoke over fire. So you're going to do the black lead on the front left. Like I said, right underneath the elbow. And then you'll take the last one and put it on the left rear right below the stifle. Alright, so we've got it going over here, and I'm going to go ahead and start printing out. And I'm going to let it run just for a little bit, just so that we can get a good solid reading.
So next part I'm going to be going over is the endotracheal tube. So there's a wide range of different sizes, and this corresponds to the size of the patient and the size of their trachea. So the best way to know the length, how to measure for this is going to be putting this up to their nose, and it's not exact, but it does give you a good idea. Putting it up to their nose in that piece of tissue that's and their septum that's right in the middle, you'll measure it up to that and see about if it's about the same width as that, you'll probably get an indication that that's the correct size. For your larger patients, you do want to make sure that it is long enough and that it is going, but you don't want to make it too long to where you go start to the branches of the bronchi. Before you do intubate with the tube, you do want to double check and make sure that you don't have any leaks. So you do want to go ahead and inflate your cuff. You want to make sure that you do have a cuff inflator. I do have this one that will help, that does have little indicators that help show you when you've gotten your cuff inflated enough. So you'll go ahead and insert the tip, push down on the inner part, and slowly inflate your cuff. As well, now this is inflated, you can kind of really manipulate it and really see and make sure that none of the air does escape from your endotracheal tube. And then you can go ahead and deflate it before inserting it into the trachea. Also, in addition to monitoring the heart rate and the on the pulse oximeter, you are wanting to go ahead and monitor your respirations, whether or not you're using that endotracheal, whether or not you are using your esophageal stethoscope. So the one that we have, it will attach to the end of your endotracheal tube, and what it will do is the air will pass through, and it'll send off little chirps, kind of, that will indicate that there is air being passed through it. There you go. Another important step in monitoring the patient under anesthesia, since the patient does tend to get hypothermic while they are under anesthesia, you do want to be monitoring their temperature and make sure they're not dipping too low. So we use just a regular thermometer that is inserted into the rectum and is monitored every few minutes or so. We monitor about every 15-30 minutes or so.
Marty Turner, DVM.
Okay, so I'm going to be placing a IV catheter. So the first thing you're going to do when doing the catheter is you're going to shave the area. Okay. Then I'm going to go ahead and just do a quick scrub on the area. Sorry. Okay. going to go ahead and take my catheter, bevel side up, and gently insert it into the vein. And then once you see a flash, you can go ahead and very gently thread the catheter through the vein. Making sure that you're still getting a flow of blood. Okay, and then next you're gonna put in your plug. Get that on. And so I'm gonna take, after you get that plugged, I'm gonna take my 1/2 inch tape. And take the catheter. And after that, you're going to take a 2-inch piece of gauze and put that underneath the plug. And then you're going to take your inch tape and tape that. Now that I have him taped, I'm going to go ahead and flush the catheter, make sure that we are still threaded through the vein. Then the last part you're going to do is take the vet wrap and do a final wrap. I'm going to go ahead and do a saphenous intravenous catheter. The first thing you're going to do is shave the area that you're going to be putting the catheter. Okay, ready. Alright. Now that I have that shaved, I'm going to go ahead and scrub the area. Good boy, Rudy. Now that the area is scrubbed, I'm going to go ahead and take my catheter. I'm going to take it bevel side up and gently insert it into the vein. Once you get a flash, you can slowly thread the needle or thread the catheter through the vein. So once you have the catheter successfully threaded and you are getting blood, you're going to hold off, and then you're going to hold it off. You're going to hold it off, and then you're going to insert the plug into the catheter. And then you're going to go ahead and take your 1/2 inch tape . Tape your catheter down. Then you're going to take your 2-inch piece of gauze and put that underneath the plug. And then you're gonna take your 1-inch piece of tape and then tape it again. And last step is you're going to take your vet wrap and wrap the whole thing. Actually, the last step is actually going to be you're going to flush the area, or excuse me, flush the catheter. Make sure that you are getting, you can feel it through the main. Alright, so in addition to the IV injections, the two other that you're going to be using in the field are going to be subcutaneous and intramuscular. So the first one for subcutaneous, you're just going to go ahead and tint the skin. You're going to mount and insert the needle, draw it back to make sure you have no blood, and then inject your medication. And then the next one, the other kind of injection is going to be an intramuscular injection. So when you're going to do that, you're going to take the muscle on the back, this one being the tricep muscle, and you're just going to go ahead and pinch it and hold it in between two hands, poke directly into the muscle, again aspirate for any blood, and inject your medication. Alright, so we're going to go ahead and induce Miss June for her spay today. We're going to be inducing her with Telazol and IV. Alright, so when you're inducing her, I'm going to have someone assist me and hold open her mouth. You're just going to want to, I already have my tube looped up and ready to go. And then I'm going to hold open the tongue. And then you're going to just press back the flap and just look for the hole in the middle. And you're going to slowly advance the tube down her esophagus. If you do have any resistance, you do want to go down in size. Make sure your tube is nice and secure and won't slip. So I have my respiratory monitor attached to the end of her tube. We're going to go ahead and flip her on her back for the scrub. And attach her to anesthesia. Alright, and now that I've got her attached and I'm not going to be moving her at all, I'm going to go ahead and inflate her tube. I do have a cuff inflator that will help show me, has a little red line to show me if I've inflated it too much. Alright, now that we've got her under anesthesia, I'm going to go ahead and apply the eye loop. I'm going to go ahead and start my scrub and clip and scrub, and to clip you're going to start right here at the xiphoid process all the way down through the entirety of her abdomen.
Is it for Apollo?
Alright, now that I've got her clipped, I want to get rid of the excess hair. I'm going to go ahead and vacuum away the excess hair. Now that I've got her properly clipped, I can go ahead and start our scrub. So I'm going to scrub 3 times, first with chlorhexidine and the next with alcohol. You're going to start in the middle and work in a spiral pattern all the way out, not crossing over a place you've already scrubbed before, all the way to the edge of your clip.
What was the hexing? Thank you. What was you said? What was the other first one that you had? Susanna. Thank you. One moment.
Okay, now that I've got her clipped and scrubbed, I can go ahead and transport her to the operating room. So the first thing I'm going to do is to go ahead and deflate the cuff. And I will detach her from the anesthesia. And when transporting, you're going to be super gentle. Thankfully she's small enough, but other dogs that are bigger, you may need help. Thankfully she's small enough to where I can do her myself, but I do want to watch out for the neck and make sure that it is completely supported the whole time, and making sure this field stays as sterile as possible. re-inflate her cuff. We'll go ahead and attach her to our pulse oximeter. And I'm going to be attaching the end clip to her tongue. Go ahead and moisten her tongue a bit. I'm going to do a quick swipe scrub again just to make sure she's completely, nothing was contaminated during transport. Is it Rio cutting?
Oh, yeah.
So I'm going to be going over how to perform CPR on a patient. So the first thing to do to determine whether or not you actually need to do CPR is to determine if your patient really is in cardiopulmonary arrest. You're going to make sure whether or not they are responsive in any way, any sort of blink, twitch, ear flick, anything like that. You know, really try and arouse them. If you get nothing, the next thing you're going to do is to test to see if there is any rising or falling of the chest. If there are none, you can go ahead and safely assume that the dog is in cardiopulmonary arrest. So the first thing you're going to start with is your chest compressions. So this demonstration patient I have here is a smaller patient, but I'm going to go over both for a larger patient and a smaller patient. So if you're having a large lab, you know, larger dog, things like that, you're going to want to really use both hands and use force and go about 1/3 of the depth of the chest, and just really you're going to go about 120 beats per minute. And then, so for your round-chested dogs, you're going to go at the highest point of the chest. That's for your labs and dogs like that. Your keel-chested dogs and your smaller dogs, you're going to go right above where the heart is, so right behind the elbow. And I did forget to mention, you do want your dog on right lateral. The heart is on the left side, so you're going to be working on the side with the heart. So, like I said, for smaller dogs and keel-chested dogs, you're going to be working right here at the heart, doing your chest compressions right here. So normally if you're going to be on the ground, you want your shoulders above your elbows. And then the next is working about the respirations. So if a dog is already intubated or it's possible for you to intubate the dog, you're going to be using the ambulatory bag. So you're just going to attach it onto the end of the endotracheal tube, and then you're just going to, you're going to make sure to go very slowly, about 10 breaths per minute, and just to squeeze, release, squeeze, release, squeeze, release, squeeze, release. But sometimes you aren't able to do, you aren't able to intubate the dog. So in that case, you're going to hold on to the mouth and then breathe into the nose. So sometimes it's good to have two people. You're going to have one person doing the chest compressions and then the other person doing the respirations, whether with the ambulatory bag or just by respiratory support. So one person on this end and another on this end. If that's not possible, you're going to do for every 30 compressions, you're going to do 2 breaths. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14. One, two. Alright, so the next thing I'm going to do is demonstrate a surgical scrub. So the first thing that you're going to want to do is to remove all excess jewelry, name tags, everything like that. So I'm going to go ahead and do that now. Take all of this off, watches off, anything like that. So now that that's done, the next thing you're going to do is to put on your hairnet and mask. Making sure that all stray hair is tucked into your cover. Then you're going to go ahead and take your mask . Now that that's done, you don't have to worry about that again. So I'm going to go ahead and set up my gown, my sterile towel, and my gloves. So I'm going to go ahead and open all of this. now I have my sterile field that is available for use. And I'm going to go ahead and open my gloves. Make sure to really keep everything sterile. So the first thing I'm going to do when starting my scrub is to go ahead and get my scrub brush opened. And I do have sterile and ready to go. Alright, so the first thing I'm going to do is get my water on and then start with a general hand wash. With an antibacterial soap. Alright, so when you're doing your scrub, you want to make sure that all the water is always running down from your tips of your fingers down to your elbows so that the contaminated water is not running back up to your hands. So I'm going to go ahead and grab my sterile brush and start with the scrub. And you're going to go ahead, the first part you're going to start with is the tips of your fingers. And I'm going to do 10 passes. And then you're going to go through each finger. And do each side of the finger. Side of the hand, go to the thumb, palm of your hand, now I'm going to go ahead and start with my other hand first before I move on to the forearms. Making sure to keep everything, start with the cleanest up here, going down to the least clean. So I'm going to go ahead and start again, starting with the 10 passes. Alright, now that I've done both of my hands, I'm going to go ahead and start back with my forearms. All the way down to your elbows. And go ahead and Alright, now that I'm done with that, I'm just going to drop it in the sink. And so when you're rinsing your hands, you're going to start rinsing from the tips of your fingers down to your elbows, making sure that everything you just scrubbed is not going to, like I said, go back up to your hands. We have a little bit of a small sink, so this is going to be a little bit of a challenge. I'm going to try my best. Alright, now that I have my hands sterile, I'm going to keep them above my head, make sure not to touch anything else. And so now I'm going to take my sterile towel, and I'm just going to start with this arm, just slowly patting down. Again, starting from the top, the most clean down to the least clean. Making sure not to touch anything else. And so I'm going to go ahead and take the other side and do the exact same thing. And again, you can just drop it since you don't want to touch anything that is non-sterile. So the next part is going to be getting gloved up, or putting on your gown. So the way the gown should be with the inside facing me. So I'm going to go ahead and open up the gown. Again with the inside facing me. Now I'm going to go ahead and leave my hands inside, so everything right now is completely sterile. So now I'm going to demonstrate a closed gloving. So I'm just going to go ahead and open up my gloves. So now with my hands still in the gown, I'm going to go ahead and grab onto the end of the glove with my closed hand. And I'm actually going to go ahead and place the palm of the glove on the palm of my hand. And so what I'm going to go ahead and do is grab the end and then place that over top. And then this can just kind of flop here, that's okay. And so I'm going to go ahead and do the exact same thing on this side. Now that I have these on, I'm completely sterile. So now I can go ahead and pull down my gloves to where they are comfortable with the ends of my gown still inside the cuff of the glove. And now I'm completely sterile, and I do want to still stay Keep my hands above this plane because from now on anything from my waist or below is considered non-sterile. I can just keep my hands right here until I need to maneuver otherwise.
Just put them on your tip. So they're full.
They didn't get a tip on that.
You too.
Just make it. It just should go easy. Yeah, we will in a minute. Force it. That's good.
They're like, we're having such a hard time getting people in because there are so many recalls. But they're having to, luckily my car doesn't have any of them, but
My day, they put some steering.
Two more.
To over the clips.
Scissors. And we'll need some too, old Daisy.
Cutting paper.
Oh, tape.
Okay, so there are a few responsibilities that you have as a sterile technician in the operating room. So the first main important thing is just you want to stay sterile the entire procedure. So there are a couple different things that can happen if you do somehow break sterility. The first one is if like something happens to your gloves where they become non-sterile. You can have a non-sterile technician open up a glove pack for you, and you can put on another pair of gloves on top of the non-sterile ones, and making your hands sterile again. If by chance you or the doctor does break sterility by dropping an instrument or anything like that, you can do a flash sterilization into the with the autoclave, and it usually takes about 5 minutes. So other than if what happens if you do break sterility, other than that, you want to you're going to be handing the doctor instruments during the procedure. You want to handle them in a safe manner. You want to hand the doctor the instruments with the handles facing them, handles down, excuse me. And then you're going to be handing them you'll be putting the scalpel on the scalpel handle, threading needles, things like that. Other than that, you are going to make sure that the operating site does stay clear of any blood, tissue, things like that. So you're going to be blotting the area as the surgeon is working on the area. And that, like I said, you don't want to maintain sterile as much as possible, but you're there for the doctor, whatever they need for you. So once you are done with the surgery, you are also responsible for cleaning up the surgery suite after the surgery. So when cleaning, the first thing I'm going to do is to get rid of any of the, towels, drapes, anything like that was used in the procedure, and take that and put it in the laundry. And if there are drapes that do have an excess amount of blood on them, I do like to go ahead and spray those with some peroxide to get them a little bit cleaner before sending them through the wash.
And then you're gonna go ahead and take your instruments. So when you're done with all your when you are done with all of your stuff that your surgeon did use during your surgery, you're going to probably dispose of the things that need to be disposed of. So the big thing is going to be disposing of your needles and scalpel blades and things like that. So those are going to be disposed of in your sharps container. Make sure that those go in there and aren't get left behind for someone to injure themselves with. Anything else is going to be like gauze or any tissue or any masses, anything that was left behind that was cut out, left as waste after the procedure, will be needed to throw away in a designated biohazard container. And then after that, I will take my instruments and take them over to where I'm going to go ahead and clean those. Other than that, you do want to go ahead and remove all of your all the things that you used in your procedure, circuits, things like that, just so that it can be replaced for the next patient. And then after that, you want to thoroughly clean the area. So really cleaning off and disinfecting the surgery table, lights, all surfaces. And any tables that were used during your surgical procedure. And if you got it, and also if you do have a the trash can in the surgery suite, you will need to empty that and dispose of that as well. Replace the trash bag for the next patient, basically resetting everything and making sure it is ready to go and clean and ready to go for the next patient. So I've had my instruments soaking in some water for a little bit. I've had them just sitting in our sink soaking in water, trying to loosen up any of the blood and tissue and things like that. So once you do that, you're going to go ahead and just take your scrub brush and use the soft side, and you're going to go through each part of the instruments, getting off any of the pieces of blood and tissue that are left behind. Then I'm going to go ahead and transfer it to our ultrasonic shaker. Once I'm done with the instrument, make sure to really open up the instruments and get in between all the different parts where stuff could be hiding. When you're putting them in the ultrasonic shaker, you want to make sure to leave them kind of open. You don't want them closed, because when that way you can still continue to get off all that debris and stuff that's left behind. Just like that. Okay, now that I've got all my instruments in my ultrasonic skiller, I'm going to take my cleaner and lubricant. We already have some diluted here ready to go, and you're going to just go ahead and fill up the scaler with the lubricant and instrument cleaner, making sure that the instruments are completely submerged in the fluid. Then I'm just going to go ahead and turn it on and let it run, and once it's finished, I'll go ahead and take them out. Okay, now that that's done, I'm going to go ahead and take out my instruments and lay them out on a towel. I'm going to go ahead and lay them out on a towel so that they
can properly dry. You don't want your instruments wet going into the sterilizer because they're going to stay wet. And now they're completely clean and ready to be wrapped for sterilization. Now that I have all my instruments clean and ready to go, I'm going to go ahead and place them in the pack. I already have my tray ready with my clean towel. And so I'm just going to go ahead and start with the larger instruments first. You can kind of keep things grouped by like forceps, needle holders, things like that. I'm going to go ahead and start with, but I'm going to go ahead and do the largest first, working my way down. Alright, now that I have those, I can go ahead and place them in my pack. As you can see. And then you're going to go ahead and take your gauze. I've already counted my gauze to 10. That way we know how much is in our pack. We, in case we know how many we have. In case for some reason the doctor does misplace one. I'm going to go ahead and put my gauze here on top. And I like to go ahead and put my towel clamps and scalpel blade on top of the gauze along with the scalpel handle because that's what the doctor, that's what we're going to be grabbing first in order to set up the drapes and set up the procedure. So I'm going to go ahead and get everything folded in. Then I'm going to go ahead and take my wrap, lay it out. I have this all cut and ready to go. And I'm going to go ahead and place my pack right here in the middle. And then I'm going to do an envelope fold. So, and when you're wrapping, you do want to get everything as tight as possible. That way it keeps the sterility as best as possible. So I'm going to go ahead and bring this over top first to where you have your two lips to the side. And you're going to go ahead and tuck this top part underneath your pack to where you have a little lip that the doctor will pull out later. So, and then you're going to take these sides and you're just going to tightly pull them in. And you'll just flip it around and take your top part, keeping it nice and flat as possible. And then you'll just tuck it into those lips that you made, leaving out a little bit at top. And then after that, you're going to go ahead and take your sterile steam indicator tape, tear out just a little bit of a piece. Don't need too much. And what this does is when it's sterilized, the little lines on the tape will turn black to indicate that it has been properly sterilized. And so then you're going to go ahead and take a Sharpie and write down which pack it is that you sterilized, you are sterilizing. This is going to be our brown neuter pack. And then I'm going to add today's date and my initials. Alright, now it's ready for the sterilizer. Alright, so I'm going to be demonstrating how to rewrap your gown after it's been washed after the procedure. So you're just going to go ahead and lay it out on your table. And you're going to go ahead and take the arms and fold them inward. Alright, and once you've done that, you can go ahead and take the sides and fold those in as well. To where
So where the two sides meet in the middle. So then the next part is you're going to take the entirety of the side, both sides. You're just going to fold them into each other, folding them in half. So now you have more of a streamlined gown. Once you've done that, you're going to go ahead and fold that in again. Try and keep it as even as possible and flat and straight as possible. And so then you're going to go ahead and accordion fold it like you would any other pack. Alright, and now this is at top, and you're going to leave these right there on top, ready for the doctor to take them out to keep it sterile. So once you do that, you're going to go ahead and take your wrap and lay it out. And then you're just going to wrap it like any other wrap with the envelope fold. So you're going to go ahead and get this in the middle. Pull it tight. It's kind of a big wrap for this. And then you're going to take this, pull it forward, and then just tuck all of that in. Leaving out your lip to pull out later. And then I'm going to go ahead and take my steam indicator tape again, place it on there, and then with the Sharpie I'm going to label that gown, today's date, and my initials. So this is our autoclave. So the one that we have is a gravity air displacement sterilizer, and basically what the autoclave does is it is a high pressure system that gets really, really hot, and with that high temperature and the high pressure, it kills any living thing that is on or in the packs. So it gets to about 250 to 270 degrees. It'll get up from about 15 to 27 psi, and it can take about 3 to 15 minutes for it to sterilize, depending on what it is that you're sterilizing. So our autoclave has different settings. It has like unwrapped, pouches, packs, and hand pieces, and that all is where those ranges fall in, depending on what it is that you are sterilizing. So the way this one works, it is the sterile water, the distilled water that turns into steam and gets really hot and creates that pressure in the system. So I do have my packs all ready to go. And what to know when you're packing the autoclave is you don't want to pack. The big thing is you don't want to pack it too tightly. You don't want things on top of each other and touching the sides of the autoclave, because that's going to prevent it from getting properly sterilized, and not because it won't have the access to the steam. Excuse me. So when you're pressing it in, you're going to go ahead and you can pull out your drawers and get everything in. We have the packs that we wrapped earlier, and I'm going to go ahead and get them into our autoclave, and then get them into it, and then I'm going to go ahead, and since I'm sterilizing packs, I'm going to go ahead and select packs, and this one will last for about 30 minutes, and then we'll press start. Another big part of the autoclave is maintaining the sterility, and just maintaining the autoclave in general to make sure that everything is getting as sterile as possible when it is in use. For this one, it includes weekly and monthly cleanings. The weekly cleanings require you to take out each part of the autoclave, and you're going to dump out all of this distilled water and replace it with fresh, clean distilled water. You're going to take speed cleaner, anything like that, and some water, and you're going to just wipe everything down. You're going to clean up the filters, things like that. The monthly cleaning is a little bit more involved, as you can imagine. You know, it requires you running through the water a couple of times. You'll run some speed cleaner through the entire thing, and you'll run a couple of different cycles, and then you're also going to take everything out again and, you know, really get it really clean with the speed cleaner, things like that. You know, you really want to make sure you're only using distilled water. It could damage the equipment. Really make, you know, and if you ever things start coming apart, or things don't stick the way that they used to, that could, you know, decrease the amount of pressure that's going on in the system, and that really could decrease the life of your autoclave, and also decreasing the sterility of your packs that you're using. Alright, so now that our sterilizer has run through and everything that we just packed is now sterile, you can double check to make sure everything is sterile. Also, side note, you want to mention, make sure that everything is kind of cooled a little bit before you take it out, or else it could be really hot and you could burn yourself. And like I said, once you take it out, you want to double check your indicator tape and make sure that it has these black lines like I've mentioned before. Really make sure that it is properly sterile before using it in the future for surgeries.